Thank you. Thank you so much, Aditi. And it's a great pleasure to be with all of you at Shaastra 2021. Of course, I live in Chennai before I moved here to Geneva. So IIT Madras is very close to my heart. I've also attended festivals at IIT when I was in medical school. It wasn't called Shastra then, but I remember coming as part of the dramatics and the music group in the late 1970s, and I really enjoyed those visits and stay on the campus. I know this year it's a virtual meeting, but I'm sure it's just as much fun. So you were asking about tuberculosis. Yes. So when I did my medical training, I always wanted to be a pediatrician. I had an affinity for both actually animals and young children from when I was a child. And I started off wanting to be a veterinarian, but then ended up in medical school. I was always interested in research, maybe because that was because of my background growing up. I had students and research and labs and all the discussion about science in the house. That might have had the impact, but I was very focused on pediatrics and very focused on research. I went to the US to do a fellowship after I did my MD at the All India Institute, and I specialized in pediatric lung diseases. And then when I came back, I really wanted to focus on pediatric lung diseases, children's lung problems, and I recognized that tuberculosis was a very important problem in India. And as far as children are concerned, it's a much more severe disease. So if a young child gets tuberculosis, a child under 1 or even under 2, then there's much higher risk of that child developing these very severe forms where it goes to the brain, it becomes meningitis, and it can have a lifelong damage to the nervous system. I also realized that in India, the whole field of pediatric lung diseases at that time was not well developed. This was in the early 90s. And many children were either being overtreated for TB or undertreated, underdiagnosed. So there was a problem both of asthma being treated as TB and of TB being missed, where it should have been picked up much earlier. And I can never forget a particular child I saw in the clinic at the Institute of Child Health, a very malnourished child who had come in with fever. And the usual practice was to give antibiotics and see if it improves. At that time, there were very few diagnostics. You could do rapid diagnostics for TB. And then the child was asked to come back after a week or 10 days to review. And if the lesion in the lung persisted, then you were more or less sure it was TB because it hadn't been cleared by regular antibiotics. In that week, that child died actually. And it really brought that point home to me that in children, every day makes a difference between life and death, and you cannot afford to wait even for a few days. So that's what actually encouraged me to continue to work in TB, because I realized that it is an important cause of lung disease and lung damage, both in children and in adults. And also I got an opportunity then to work at the Tuberculosis Research Center soon after I came back from the US. And I realized I had this environment and opportunity to combine, what's being seen in the clinic and in the community by collaborating with my doctor colleagues at the Institute of Child Health. And at the same time, we had an excellent environment for research where you can use the latest immunological tools, the biochemistry tools, as well as good epidemiological and statistical backup to undertake good studies. So yes, my intent in the beginning was to cover the whole of lung diseases in children, but then I decided that if I had to focus, then I would pick TB.
Okay, thank you, ma'am. That was a very great story. So next we have your work at the WHO and National Institute for Research in Tuberculosis. So as the director of the National Institute for Research in Tuberculosis, how did you make a difference in the diagnosis and treatment of tuberculosis in India?
So the first thing I'd like to say is that medical research and science in general, as you all know, you're students of engineering and science, is an incremental process, and you build on knowledge that you already have, and then you increase that knowledge base, and that makes an impact on a disease, on diagnosis or treatment. It's very rare that one event or one study or one discovery makes a huge difference. It happens once in a while, but most of the time it's incremental changes. And so it's very hard really for one individual or even a group to take credit. It spans over a long time and it involves lots of people. So that's the first thing that I would say. However, when you're in a leadership position, obviously you get to drive some of the work of the organization, and you can prioritize, you can bring in new ideas and new collaborators, etc. One of my dreams was to do a project, an ambitious project called the Zero TB City Chennai project, which would involve really going into the community and putting in place all the different things that would need to drive TB down. TB is a very complex disease. It has a very long latent period. It's not an infectious disease like COVID, where you get exposed, and if you're going to get sick, you'll get sick within 14 days. You'll get the infection. Whereas for TB, you can catch the infection when you're young. Nothing will happen for 30, 40 years. And then suddenly when you're 50 years old, you may develop lung TB, pulmonary TB. And we still don't know exactly what drives that. What is that event? We know that diabetes can exacerbate it. We know that if you get HIV or some other immune suppressing condition, your TB can flare up. If you're a smoker, you have a higher chance of it flaring up. But we still don't know exactly what happens. So that makes it very challenging disease to study, because this bacterium can live in your body dormant for so many years, just hiding inside your macrophage somewhere. And then after 30 years, it wakes up and it starts multiplying, Of course, you can also get a recent infection as well. So some of the studies we did were really to look at the duration of treatment. TB is treated with very long courses of treatment, 6 months for drug sensitive, more than 2 years sometimes for drug resistant TB. You can imagine injections for drug resistant TB, and the fact that you have to follow people up for a long time, because even after treatment completion, you can have a breakdown and recurrence. So one of our goals was to shorten TB treatment by doing clinical trials. So we used to keep trying different combinations of drugs in groups of people, what's called randomized clinical trials. Half the people get the standard dose and drugs, half the people get something new that you're trying. And our goal was shorten the treatment. So we tried 3-month regimens, 4-month regimens instead of 6 months. And the 4-month was actually quite successful. Wow. The other one was trying out new diagnostic tests. So molecular diagnostics started becoming available. And so we needed to test those to see if we can use them on a broad scale and if it would be cost effective. Another interesting project we did was in 2 districts. The government was very, at that time, reluctant to start HIV testing for all TB patients because they thought it would add to the stigma and might drive away patients from the program. At that time, the program was really trying to pick up. So we said, let's try it in 2 districts and see what impact it has. And we found that if you offer people HIV testing after proper counseling and so on, there was no reluctance or stigma, and it didn't actually drive people away. So very quickly, then it became a national program. Every TB patient is offered an HIV test. So the research ranged all the way from clinical trials, operational research studies, some epidemiological studies like the prevalence surveys that we were doing, to things like implementation research, or what we call, the implementation science, or when you actually demonstrate something at a large scale and see that it works. And that's where the Zero TB Chennai program started with the Corporation of Chennai, with many NGOs and partners, to say, can we drive down TB in one city and demonstrate that it's possible? Now, that program is still going on. It was slow to pick up. It's very complex, involving lots of partners, lots of new initiatives had to be put in place. But I think now the results are coming in and we'll be able to see what kind of impact it has.
Those are some wonderful efforts that you and the institute have taken. And moving on to your work with WHO, Dr. Tedros, the Director General of WHO, is from Ethiopia. And you've also worked extensively in India, as you just mentioned, especially in Chennai, etc. So before this, most of the senior positions in the WHO were held by experts from developed countries. So how do you think your experience working in a developing country helped you prepare for this role?
Yes, I mean, I never had my goal to be in WHO or anything like that. I was actually very happy working on TB, and then later I became the head of the ICMR, and I really wanted to focus on building research capacity in our medical colleges across India, because I still think there's far too little medical research that happens, or health research that happens in India, and there's too little multidisciplinary research. I wish there would be many more collaborations between IITs and medical schools and hospitals. It's beginning. I think IIT Madras is one of those which has those interdisciplinary research linkages, but we need more. So when Dr. Tedros became the Director General, one of his commitments and goals was to have a very diverse team. He had promised that he would bring gender balance in the senior leadership team and also diversity. So when he selected his team, it's literally like the whole world. If you see all of us sitting together, it literally spans every region in the world. We're about 12 or 13 of us in the senior leadership team. And so I think it is wonderful that he did that. We had a balance of 60% women in his team. Wow. And that commitment continues. So many of the senior leadership are women from different parts of the world. And so I think we bring this diversity of experience, having lived and worked in a country like India, or one of my colleagues is from South Africa, another one is from Brazil. We bring those experiences. We know the real life, how things happen, both in terms of how the government operates and health system operates, but also in terms of the real problems of people. And so we're able to remain grounded when the discussions happen, and maybe sometimes even remind people that this particular program may not work or may not have a big impact because you're not taking into account, these specific contexts in which things happen. So also for us, many of us who come from the developing countries, you constantly have, in the back of your mind, the knowledge that so many people still do not have access to quality health services. So many millions and millions of people around the world. And so your work then gets driven always by the fact that you need to bring that quality affordable. Even when you're developing new products, you're always thinking about the issues of access and equity.
Okay, ma'am. That's a wonderful initiative by Dr. Tedros, and it's wonderful to see you there on that team. And coming to pandemics, and WHO, we're seeing new pandemic health threats in recent years, from Ebola to Zika to a new malaria strain developed recently in Cambodia. So, how might the WHO prepare countries and international health networks to contain and combat these?
And that's a really great point. The WHO has been saying for many years to countries that we need to prepare for a pandemic. And most health leaders and experts, public health experts, have known that the pandemic is not an if, but a when. You cannot predict when it happened. And it suddenly happened out of the blue on the 31st of December 2019. So there is a whole... after 2015, when there was a big Ebola outbreak in West Africa, and more than 11,000 people died, in these three countries of Guinea, Sierra Leone, and Liberia, poorest countries in the world, there was no way of stopping that Ebola. It took a long time, actually, for it to clear. At that time, there was a lot of global review, advice, reflection on what was missing. And there was a lot of inputs given to WHO. And so WHO really ramped up its emergencies program after that 2015 Ebola outbreak, strengthened the emergency program with the focus mostly on response and detection and response, but also on prevention. Now, one thing about prevention is that even though we all say prevention is better than cure, when it comes to investing, the heads of finance and political leaders do not find it so appealing to invest in prevention. as in response, right? Or building a hospital or putting up a new infrastructure is always more appealing than something which is invisible behind the scenes, because strengthening preparedness and prevention means that you have to attend to all the risk factors. It's all upstream, it's all interlinked. It's not just the health system alone. Like in the case of pandemics, we are talking about animals, and we're talking about the environment, and we're talking about animal and human interactions. That's how these diseases emerge. 70% of new zoonotic of infections come from zoonosis, from animals. And all the previous pandemics that you mentioned, all originated from viruses in animals through an intermediate host. So you need to work with the sectors of animal and veterinary health, with environment, deforestation, urbanization, animals and humans living closely together. So surveillance needs to be across these animal and human health. The response also needs to be coordinated, and you need to invest also in surveillance, in data systems, in laboratories and laboratory networks, and most importantly, in human resources. You need people who are trained in epidemiology to be available at the district level, so that as soon as there's some hint of something unusual happening, these district level epidemiologists can go and investigate and quickly find out, because early detection is important before it starts spreading out of that area. And so for Nipah, for example, in Kerala, that was done very effectively. It was contained, it was immediately action was taken, and it was an excellent response. On 2 years in a row it happened. So that needs to happen everywhere, across the country, across the world, because as you know, pandemics can arise from anywhere, and the world we live today, it spreads very quickly. So this kind of investment has to be made now. It may cost a few billions of dollars, but ultimately it will prevent trillions of dollars of losses to the world economy that we're seeing today. But it needs a systematic, a sustained, and a long-term investment. But this is the time to start.
Okay, ma'am. So as you mentioned, it causes, trillions of dollars of loss to the economy. So coming to COVID, which is, the latest pandemic here, and lockdowns impose high collateral economic costs, which are harder for some countries to bear. So there's also a risk of an increase in deaths from other causes because of making it harder to access medical resources. So what's your view on how countries can approach this trade-off?
No, that's very correct. And in fact, we did a pulse survey. WHO did a pulse survey in about 100 countries in the middle of last year. We're repeating it again just now. I haven't seen the results yet. That actually showed that about 75% of countries surveyed had some disruption in essential health services. And this impact was much more felt in the low-income countries. Immunization services, antenatal, cancer treatment, malaria, tuberculosis. In India, tuberculosis case finding went down by 50 to 60%, and it's still not back to the baseline, which was pre-2020 lockdown. So many countries also, what they've done is they've gone and looked at excess deaths, excess mortality that happened in the last 9 months or 1 year. And they found that some of it can be accounted for by COVID, but some of it cannot. So that actually demonstrates what you were saying. The impact on the health system has impact on people's health, and people will die because they didn't get timely attention to their other health needs. So what it needs is resilience. So this is linked to the previous answer. Your health system, when it faces a shock like this, has to be able to do both. It has to be able to respond to the new threat, the pandemic, but also maintain the existing services. And that means you need, extra human resources that you can call upon at that time. You need the systems and the thinking and the plans already in place for how you would do. Like, for example, the telemedicine, telehealth has really picked up. There's the e-Sanjeevani platform of the government of India. Many countries started using much more telemedicine services because the travel was disrupted, people couldn't come, and so on. Those things, they become a part of the system. And if we can think ahead and plan for what will happen when there's when there's a shock like this. You need, of course, the financial resources to come in, but you also need this trained manpower. And what happened is that all the manpower was diverted to doing the COVID work, and so the other programs actually suffered. So again, this is something that one needs to think, plan ahead, and then put in the resources, to make it happen. One interesting fact is that, the lower income countries, many of them have done better than high income countries in terms of the public health response, perhaps because they're used to doing infectious diseases like TB, and, so we have a whole workforce that's trained in contact tracing, that goes home to home. We have community health volunteers, we have ASHAs. They are the ones who actually came to the rescue for COVID. Whereas in the developed world, while their medical system is very advanced, their public health system in many countries has been neglected over the years. And so that aspect of it actually collapsed. So I think there are lessons to be learned, however rich or poor the country, every country can learn now from what went right, what didn't go well, and make those corrections.
Okay, ma'am, that's nice to know. But coming to India, and especially the testing in India, India has been using what's known as a PCR test, which is regarded as the gold standard of testing very widely. But currently, only 60% of all tests use this method, and many Indian states who are in charge of their own health policies have switched to rapid antigen testing, which is faster but less reliable. So, what form of testing should India adopt, and should India be testing more broadly?
Testing is really an important issue, and at the beginning, we found that many countries didn't have any diagnostics, and those that had were not enough at all. So, in fact, across the world, we found diagnostic testing was much lower than what it should have been. Over time, of course, it picked up, and India did well because it expanded the PCR capacity from one lab at the beginning to almost 2,500 labs across the country now, and we have so many rapid diagnostic tests and so on that have been developed. Now, the issue is that testing is an important part of the response, but it has to be taken in the context of what you do. It's not just enough to test. You have to take action after that test, and you should also know where to test and when to test. So there's a lot of, I think, heterogeneity in the response in terms of state to state. Some states have done much higher levels of testing than others. The WHO does have a benchmark for how much diagnostic testing is enough. But for example, if you see consistently that your test positivity rate is above 5%, that means you should be testing more. And then you need to look at trends, and you need to look at testing. Are you doing enough testing to detect clusters, for example? So, so the strategy of testing really needs to be decentralized. It has to be appropriate to the context. So an urban slum may have a different approach. And I think Tamil Nadu did well. In Chennai, they set up these fever clinics at the time when cases were really going up. Go into the community where there are more cases. So use data. And I know again that IIT Madras has worked a lot on using mobile, connecting the mobile numbers of people who've been tested to look at the geo mapping of where there seems to be more clustering, so that the government can actually concentrate there. So if you find there's particular urban settlement, which are the high density areas where the infection spreads very quickly, go in there, try and test everyone. This was done in Dharavi also. Find every possible case that a person could be infected, and then provide a supportive isolation facility. Because as you know, in our urban slums and high density areas, you cannot ask somebody to isolate at home. It's impossible. There's no facility. So you need to provide supportive isolation, maybe give them make sure that their families are looked after, in the sense that many people are surviving on daily wages. So we also have to think about the social and humanitarian aspects of the response, so that people are not starving because they've been put into isolation or quarantining the family members. And that's why there was some reluctance initially. People were afraid that they would be locked away somewhere. And over time, I think all of that improved. But it again shows that you need an intersectoral response in an emergency like this. It's not the health system alone that can cope. You need all of the other departments and ministries to really play their role, whether it's in providing additional food grains at that time when people, had lost their jobs, whether it's, making sure that there's social workers out there to help families in distress. And I know there were many student volunteers also at that time who were manning these call centers and providing advice to people. So those first few months were very, I think, confusing for everyone. It took some time for things to fall into place. But now we understand the disease much better. We understand epidemiology. One of the things about this infection is it spreads in a super spreader type of events quite often. So we know that only 15 or 20% of people who are infected are responsible for 80% of infections. So we need to be able to identify those particular situations where these kind of super spreader events can happen and completely avoid that. And I think that will need to continue through 2021 as well.
Okay, ma'am. Thank you for that. But coming to COVID and WHO's response, so we've approached a year since the first cluster of COVID cases were reported to the World Health Organization. On this and on other major global health issues, how is the WHO using its experience of working with philanthropy?
Yeah, that's a really good point. And I can give you a couple of examples of working with philanthropy. We set up something called the Solidarity Fund. And the Solidarity Fund, there was a big fundraiser, big gala event called Global Citizens, where there were lots of celebrities and musicians, pop stars and all that who sang. This was in April. And that raised, $30-40 million. So overall, the Solidarity Fund is open to individuals and philanthropies, corporates, anyone who wants to contribute to the response. And over $200 million have been raised in the last year. We, of course, also work with large philanthropies like the Bill and Melinda Gates Foundation is one of them, who've played a very important role, particularly in the setting up of the ACT Accelerator and the COVAX facility, which, as you know, is the global mechanism to accelerate the development of new tools and to provide equitable access around the world. So a few philanthropies have, along with other global health partners, have worked on that. Individuals want to contribute, so that's why the Solidarity Fund was set up. And now we're setting up a WHO Foundation, which will also enable both individuals and corporates to provide grants, which will then be spent on worthwhile projects. Currently, the biggest program we have is the ACT Accelerator. There's a budget there of about $28 billion, of which about 8 or 10 have been raised. So there's still a big gap. And that is to basically provide vaccines as well as diagnostics. And if there are new therapeutics that get developed, new drugs, then those as well for all low and middle income countries over the next year. It's just for this year. So it's both to accelerate development, because we see that the acceleration of R&D happens only when you invest large amounts upfront, and particularly for new products. For vaccines, there was a lot of investment from governments as well as from the private sector itself. But for things like diagnostics and drugs, it really needs both the push and the pull mechanism to make that work. We've also worked with tech companies. I should just mention that, because this is a change for WHO to be working with these big tech companies, particularly on the social media platforms. I think our presence on social media really went up over the last year. And not only that, we worked with them basically to remove misinformation and misleading posts. So whether it's YouTube or Instagram or Twitter or Facebook, as soon as we highlight to them that there's a misleading or a false or an anti-vaccine, message out there, they immediately flag it and they remove it. And they also promote the users of, say, Google to go to a credible source of information. So if you type a search word of COVID-19 vaccine, it will take you to a credible source, whether it's a government source or WHO or CDC, rather than to some anti-vaccine website. So those have also been some new initiatives that have been very rewarding.
So those are some great initiatives. And coming to the point of information and misinformation, so some people state that across Europe and Italy, the most widespread is strain G, while the L strain from Wuhan is gradually disappearing. So is there any evidence to suggest a variance in its virulence in different countries?
So the variants, as you know, is a very hot topic just now. Yeah. Actually, we've been tracking this from the beginning. And as you rightly said, the original Wuhan strain was very quickly replaced by a strain called the D614G. It had a mutation in that 614 position. And at that time, it was considered to be more transmissible than the original Wuhan strain. Anyway, that became the dominant strain way back in February, March last year. So since then, we've been, there's a public database called GISAID, where luckily people from all countries have been putting their whole genome sequences there. We have currently over 630,000 whole genome sequences. But then there are gaps. India is one of the countries that's done, in terms of numbers, quite a lot of sequencing, not enough in terms of, how much they could do. But large parts of the world, from Africa, for example, are not represented. So there are gaps which we need to fill. But the main point is that now there is a much better understanding, and we've just come up with the nomenclature yesterday. How do you define a variant of interest? And then how do you define a variant of concern when you start getting worried about the mutations? And that's based on the studies. You need to look at, is it becoming more transmissible, more infectious? Is it causing more severe disease? So the clinical pattern different. And is it becoming more resistant to the antibodies that people have, either from natural infection or vaccination? Those are the three areas that we worry about. And it does appear that some of the mutations found in the South African strain, as well as in the Brazilian strain, now being detected in New York, a few cases reported in India, have a mutation called the E484K, which does seem to protect the virus from the antibodies that people might have from vaccination or natural infection. So we have set up a group, and again, it's a multidisciplinary group, to look at what's happening in terms of epidemiology, to track the mutations that are happening, to look at the laboratory experiments that are being done with each of these new variants, to look at the vaccine response, and then to make recommendations on whether a new strain needs to be used for a vaccine for the future, just as we do for influenza. But one thing which is clear is that whether the virus has mutated or not, it still responds to the same public health measures that we've used in the past. So even in countries like South Africa, you see the curve has actually now come down, despite the fact that the infections were due to the new variant. They put in place the same measures that were done in the past, and it's happened without the use of vaccines. So while these variants need to be watched carefully, and we need to decide what action to take, it doesn't mean that we can't take action, because we know the steps that we took earlier, the same actions will work against these new variants as well.
Okay, but coming to the vaccines and these variants or mutations, do these mutations impinge on the process of developing effective vaccines?
So as I was saying, this is something that needs to be studied as we go along, and as vaccines are getting rolled out. We don't know for each of these variants whether the vaccines that are made from the original virus, what we call the wild type, will continue to be effective. So far, we've got data on the B117 variant, which is the variant described in the UK. Vaccines have been found to be very effective, maybe a few percentage points less. But as we've seen the data coming from UK, coming from Israel, coming from Scotland, in countries which have really ramped up their vaccination, hospitalizations have dropped, serious illnesses have dropped, And even asymptomatic infections among healthcare workers have come down. So it's very encouraging news that the vaccines are preventing both severe disease, but also seem to be preventing mild and asymptomatic infection. Now, we need to do that systematically for the other variants. For the South African variant, I think all of you might have seen the data that some of the vaccines that were tried there were less effective in terms of, instead of 85% efficacy, you're getting like 60% efficacy. But what's important is even there, it's preventing severe disease and illness and death and hospitalization. And that's our major goal right now, is to prevent. It's okay if you get infected and you have a mild cold and you recover in 3 days. What you don't want is people getting sick and going to hospital. So vaccines can stop that, then that's good enough. And so now the goal is really how can we step up vaccination in all countries, even as we keep the public health control measures in place.
On the same note of vaccines, some countries such as India and China have recommended traditional medicines or Ayurveda as effective immunity boosting treatments. So is there evidence to suggest that this can actually work against COVID-19?
So you're right. I mean, there are lots of traditional medicines being tested in different countries. Africa has their own traditional medicine. China has, India has. So I would say that at least as far as Ayurveda is concerned, it works on the principles of boosting immunity, and making your body, more able to fight infections. So perhaps it will work better as a prevention than as a treatment. But whatever the medicine, whether it's allopathic or traditional, it has to be tested and we need to see the data. Without that, it's impossible to say which one is going to work or which one isn't going to work. And we've seen early on, there were claims about various drugs, including hydroxychloroquine and other antivirals, which when they were tested in clinical trials in large number of people, were found to have no effect. So one case or a series of cases may give you a hint, but it's certainly not enough to prove that it's working. And so what we need are, in India, well-designed studies of traditional medicine treatments for prevention, for early treatment, which can actually give us that evidence that we need in order to really say with confidence that, yes, this works and it should be scaled up.
Okay. But some sources say that vaccines have been made too quickly, while others say that vaccines are the need of the hour, especially with them having taken about 5 years to be made on an average in the past. So could you tell us your view on the situation?
Yes, I mean, this is one of the amazing, I think, scientific accomplishments in the last year that I've witnessed. And certainly none of us expected that you'd have a vaccine in less than 12 months. We were aiming for 18 to 24 months because the previous record was like 4 years. Ebola took about 5 years. Mumps vaccine was developed in 4 years. Zika also took about 4 years, but by that time Zika had died out. So we thought we can compress it to 18 to 24 months. So what happened is there was a lot of work that's been done over the last several years on some of the platforms, like the mRNA platform, as well as this adenovirus platform, including the chimp adenovirus that's been used by the Oxford group and also human adenovirus. So what the scientists were able to do is very quickly, as soon as they got the genetic sequence of the SARS-CoV-2 virus, they plugged it on the platform. And basically the vaccine construct was ready in a couple of days. And then it had to go through the clinical manufacturing process and get into clinical trials. And that's where agencies really helped to coordinate, like the NIH, for example. Okay, they have a network of clinical trial sites across the country and across the world that they have developed in the past for HIV. What they did was use those clinical trial sites quickly to do the trials of vaccines. So they picked 6 vaccines in their Operation Warp Speed and tested them. And also, of course, they got a lot of infection in the US. So they were able to get the trials done quickly. The endpoints were quite fast. And at the same time, both the companies and governments invested in manufacturing, scaling. So normally things that would have happened in sequence happened in parallel. Phase 1 trial went into phase 2 without any delays. The regulators were ready. They were looking at the data all the time. There was no delay in approvals. Phase 2 went into phase 3. And even before the phase 2 and phase 3 was happening, manufacturing scaling up was happening so that you are ready to manufacture hundreds of millions of doses. Now, that's a risk. It's a financial risk they are taking, but it was done because it's a pandemic. And then there was a lot of regulatory harmonization across the world. There were criteria. WHO was involved in setting up the criteria, the benchmarks for a successful vaccine. We were working on the assays, standardizing them. There were investments being made into labs to standardize assays and animal models. So there was a lot of global coordination in which we were involved, but also tremendous hard work, mainly by scientists working in the companies, including those in India, where we now see a large number of candidates. We have, of course, the Covishield and Covaxin, but we also have other companies that are coming out with some very innovative new vaccines, including DNA and RNA vaccines. So it's been great to see the innovation happening in this field, and I think it's going to be for the future really something. Again, we talked about pandemic preparedness. One of the areas of preparedness is to have this vaccine platform, so you can quickly, within a few months, develop a new vaccine for a new pathogen.
That is some wonderful news, but along with vaccines, there's also this topic of herd immunity. So herd immunity is a form of indirect protection from infectious diseases that can occur with some diseases when a sufficient percentage of population has become immune to an infection, right? So we don't talk about herd immunity for protection against influenza or some other common viral infections. Then why is it discussed so much with COVID?
Yes, that's a very good question. So we discuss about herd immunity basically when we're trying to protect the population from a serious illness. And you mentioned influenza, and for that it hasn't been possible because we don't have an effective vaccine. The vaccine efficacy for influenza varies between 40 to 60% from year to year. And as you know, the strains keep on changing. So every year the new vaccine has to be developed. And it's not very widely used. It's given to high-risk groups to protect them from severe illness. For COVID, we know that it's a much more serious illness than influenza, that it has a higher mortality rate, particularly in the older age groups. And it also has long-term effects. We haven't talked about long COVID, but it has 10% of people seem to have long-term and lingering effects. So it's not an infection we want to continue. And so we would like to protect the population. That's when herd immunity comes in. And the way herd immunity gets developed is through vaccinating a significant proportion of the population. And how much you have to vaccinate depends on certain properties of the virus, how infectious it is. So for measles, which is the most highly infectious virus, you have to protect at least 95% of the population. For SARS-CoV-2, we think it's somewhere around 70 to 80%. It's still a high percentage of the population. So we need to get to that point. Of course, there's natural infection also happening. Again, the question is, how long does natural infection protect somebody? Is it as good as vaccine-induced protection? Which is why we recommend vaccines even for those who have the natural infection.
Okay. So, ma'am, coming to your personal journey, as the first Indian woman to hold the position of WHO's Deputy Director General, were there times when working as a woman scientist proved challenging?
So early in my career, it was challenging, I should say, because I remember there were times when I was a younger scientist at the TB Research Center, and my director would ask me to go to Delhi to attend meetings, expert group meetings, and so on. And I would always feel that I was, not being listened to as much or taken as seriously, because the majority of people in the room would be men, and they would mostly be older men. And so for a younger woman to be in that environment was difficult, was challenging, because you often felt that you were being brushed aside or not taken seriously, or not even being given an opportunity to speak. You would be drowned out by the louder voices. that's something that's gradually changing, I think. But I think it's still very much part of many of our institutions. And it's not just in India, it's across the world. At the WHO, as I said, Dr. Tedros, of course, made it one of his main, it was part of his, yes, that he would have gender balance and geographic diversity. So, but even then, there are, ingrained behavioral ways, systems, and cultures in many organizations. I should say that in the life sciences, and particularly in medicine, I think there isn't much of a gender balance problem. In fact, looking at statistics recently, I think there are more girls than boys entering medical school. So maybe it would be the reverse after some time. But it's more in the decision making and the power structure where this becomes a problem. As you see, if you look at heads of institutions, then you start seeing the difference between men and women, even though at the lower levels you may even have more women than men. And it's that's been well documented, that starting from a master's career and a PhD, and then faculty, and then senior faculty, and then heads of institutions, you gradually see that changing to having much less women in positions of power. And that's where I think conscious decision making then becomes. The selection committees really need to be very conscious about not just gender, but there are other factors in society which make one less, again, it's the power balance is shifted. And therefore, it's not just gender, but we have to take into consideration those others. And I remember one of the ministers, in fact, telling me herself, a woman minister, that when she first walked into the governing council meeting of the IIT, she was the only woman there. She was a minister. So all the members were men. And she questioned this. And it was basically people had not even recognized the fact that this was a problem. So I think the first step is to recognize that not having a woman on the board in the decision-making body is a problem. And then trying to fix that. So it's happening, but it still needs, I think, constant reminder that this is important.
Okay, ma'am. Another question about your life. As the daughter of MS Swaminathan, a geneticist regarded as the father of India's Green Revolution, what are your memories of growing up with him?
Well, I have very happy memories, in fact, of my childhood. I grew up at the Indian Agricultural Research Institute, also called Pusa Institute in Delhi. This is where my father worked, and in the 1960s, there was a lot of excitement because he, from 55 onwards, was working on these high-yielding varieties of wheat and rice. So I remember many Sunday trips to the villages in Punjab and Haryana, where these high-yielding varieties were being tested. And by my father had a very good relationship with the farmers in those areas, because ultimately the success of the program was that the farmers took it up and decided that it was a good thing to invest in. So we would, and Delhi in those days was very different. The population was very little, much less. I mean, compared to now, there was, not much of air pollution or anything. We had, I used to cycle around in Delhi, which I think would be very difficult to imagine now. So as a young girl, I would cycle to my grandparents' house on Sundays. We used to go for picnics. And one thing my parents did was they tried to take us to different parts of India. So quite often we would, during our summer holidays or October holidays, we would go to different parts of the country and were exposed to different cultures, languages, the way people live. We were also, of course, exposed to different organizations and institutions, because practically anywhere in India we went, there would be a branch of the ICAR institute. So we would end up visiting, veterinary institutes, potato research centers, tea and coffee research institutes, so dairy research. So we got to see that aspect, but also got to enjoy life and see many, many parts of India. And I think meeting all of those people gave us a very, I think exposure matters a lot. People who've had a wider exposure during childhood tend to understand, I think, that especially if you're a child growing up in an urban environment like Delhi, I think it was important for us to see what life in rural areas was like. And we really enjoyed that.
That's very nice. And as a final question, is there any message you would like to give to the bright minds watching this session, waiting for the world to get back to normal?
Well, I think a lot depends on your generation. There is a lot of hope that we have that you can change things in the world. And I think the pandemic has taught us a few lessons. One is that the world is one place, that there is no place for division by country, by religion, by caste, we're all one, ultimately, one human race, and our destiny is all intertwined. So what we do affects not only us, but affects the whole world. So the things that I would really be concerned about are, of course, the environment and climate change and the way we're destroying our natural habitats, the speed at which we're destroying them. But at the same time, I see hope because of the movements of young people who want to protect the environment, want to do things, and are using your skills and innovation and what you know about technology there are wonderful things I read about every day about technological fixes and innovations for each of the problems that today we face, whether it's plastic pollution in the seas or it's air pollution. So again, how do we use science and technology to fix the problems that we have today and to make the world and its environment more sustainable? So I think similarly there are challenges in education. I think there are large parts of our world, and particularly in the pandemic, we've seen 1.6 billion children were out of school at one point of time, and in India alone, I think it's millions and millions of children who are being out of school because schools have been closed and they do not have access to online learning. So again, because of the inequities we have in our societies, there are many who are losing out on educational opportunities, and it's going to have a huge impact. So what can young people who are in a more privileged position do to help those underprivileged who, with their education, with their learning, so that they can catch up and they can again become productive members? Because without a good education, that's what makes all the difference, right, between being a productive member of society and not. So I think always keeping in mind that anything that we do should not worsen the inequalities that we already have. And this is one concern I have about the digital revolution, is that for many people, it's not possible to get onto an online world and to be able to do their work in a way in which many of us are able to. So we have to keep that in mind and not have another group of people who are digitally excluded. And then finally, I think it's again about solidarity. It's about collaboration. It's about not being in ivory towers. And it's about interdisciplinary coming together. And I think the most successful inventions today are because of interdisciplinary collaborations. And I hope that in the future, we'll see younger people engaging much more in that and contributing towards, a much better world in the future, where people are happy, living in harmony with nature and with each other. I mean, that sounds very utopian, but I think it's up to us, because whatever problems we've created today are, we are living in the Anthropocenes, which means that human beings are in control of, what we're doing today. And so we should be able to change the future if we want to.
We'd like to end on that positive note. So we are extremely honored to have you with us, and thank you once again for being a part of our online lecture series. Please find the attendance and feedback form link on the chat. Kindly do fill the same. Participants who attend 4 or more live lectures as a part of Shaastra Spotlight 2021 would get e-certificates. Next up, we will be having Dr. Frank, Nobel Laureate in Chemistry, at 5 p.m. We request you all to attend these lectures too. We thank the audience for your patience and hope you had a wonderful time. Thank you. Thank you so much, ma'am.